Yeah, I would like to thank the organizers for inviting me. I've been to California after 12 years. I don't know what I was doing for last 12 years, but it hasn't changed much. But it's a pleasure to be here. And the hospitality I've seen for the last 2 days is incredible. I don't think we're as good as you guys in the East Coast. So we better do something different. So I've sort of tailored this talk around what the theme of the session is, and I think I'm going to take it a little bit further than what the two other speakers before me did. So here is our vision, and I think it will sort of broaden what we heard in the last 2 days. And I think, as Brock joked in the beginning, that I'm going to give you an overview of what happened over the last 2 days. I would summarize this. What basically is happening? How do academics interact with people in the clinics, and how do people interact with the patients? And I think the key to this is how we basically design the innovation, and then how do we take patients into account? We can't exclude academics if we're looking at patients and clinicians. So I think that it's a merger between the three, and the interaction between the three is the key. And if we don't interact well, I don't think this is going to happen very often, and it's not going to happen very efficiently. So I think the interaction between academia, the industry, and then the patients is the key to the success for innovative therapies in the future. So I think I've listed a few things here that result in patient care. The cores are the key, which basically you need to run a lab, and then the research areas where I've just outline it for our kind of work. What we do is to develop mouse models, and then cell therapy for cancers and neurological diseases, and then how do you take these out of the academia into the industry through GMP facility, clinical trials, and patient care. And I think if you don't, as an academician, if you don't interact with industry, this is not going to happen. So that's where the interaction between the academia and the industry is the key. So I'm going to give you 2-3 examples of our work, what we've done in the last decade or so. And we worked on brain tumors, and again, it's an aging-related disease. So it's in this, again, in the bigger theme of aging. GBMs are most common in adults after 45 years of age. So this is one of the unmet needs, and the reason why we work on this is not by default, but also there's a personal reason, and plus that nothing has changed in the last 20 to 25 years. So the patient survival has gone up by 2 to 3 months in 24 years. And I think that is probably due to good imaging techniques, not that we have developed good drugs, not that we have understood brain tumors well, and I think something has to happen. So if you look at 60% of the primary brain tumors are diagnosed every year in USA alone. And some of the, I was surprised to learn that around 38 to 40% of melanomas end up in the brain. So 20 to 30% of the breast tumors end up in the brain. So brain is a hub of many of the metastatic tumors. So it is, and I don't think we have any answer as of now, and we're trying to find answers. So we believe that, I don't think it is the therapeutics that haven't been efficiently designed. We also, I personally believe that we haven't understood the brain tumors well. And I think if people who are at the helm of creating new therapies, if they don't understand the target, the disease, I don't think we will ever be able to develop a good therapy. And I think that's the key here. So if you look at the brain tumors, so I've sort of outlined this so tumors are graded as grade 1 to 4, and they, as Evan pointed out, that it's one of these rogue neural stem cells that starts proliferating in the brain. And then as the tumors go from grade 1 to 2 to 3, they sort of develop a necrotic core. They become vascularized. It's one of the few tumors which gets vascular at grade 3. It's not among most of the tumors which need blood vessels early on. This is one of the few tumors which needs blood vessels later on. And then you have a full-fledged tumor, which is highly vascular, is highly necrotic, and has another problem, that there are some cells that come out of the main tumor mass and form metastatic deposits. So it's very complex. So of course, there are targets on these cells. There are targets on these cells that have been explored. EGFR is one of the targets. Avastin has been used to take care of angiogenesis. So there have been a number of therapies that have been developed, but I think what I'm going to point out in 2-3 slides is what happens in the clinics to these patients. We can take a tumor cell. So if you look at PubMed today, number of studies that are done on brain tumors that were published today have taken a patient cell or a tumor cell and have implanted it in the brain and given the mouse a drug and shown there's efficacy. And we've been doing this for the last 15, 20 years, and I don't think it's going to change if we keep on doing the same thing again. So our approach is a little bit different. What we've done is we've taken stem cells, and we've engineered those stem cells, and we're trying to target receptors on these cells and on the endothelial cells. That's the approach. So basically, let's go back to the stem cells. Again, I don't want to spend too much time on this. We've discussed this since yesterday, that stem cells replicate by themselves, differentiate into different cell types. And if you sort of summarize these, there are 3 different cells, and this is for the students in the audience as well. You might be confused hearing about embryonic stem cell, then adult stem cell, and then a cancer stem cell, and an iPS cell. So they're basically 3 different types. And the advantage of using adult stem cells is that you can take it from the patients and put it back in the patients without any, extensive modifications like iPS cells. So we've done a lot of work with adult neural stem cells and adult mesenchymal stem cells. And why use them for therapy first? That's the first question you in the audience would ask. Why would you use them for therapy? And I think Evan in early 2000 was one of the pioneers of showing that these cells, adult neural stem cells, migrate to the areas of the tumors in the brain and other parts of the body, and they can be modified to express or release a variety of anti-cancer agents, and also can disseminate to solid tumors and micrometastatic deposits that are in the brain, for example, in the brain. We have colored this scheme. We now know from my lab, we figured out the timing of the migration of the stem cells. So the red are the modified stem cells, the green are the tumor cells, and we can now tell you how the stem cells move, when they move, how far they move, which ones move faster, which ones move slower. We know that neural stem cells move faster in the brain than the mesenchymal stem cells. And this has been sort of documented well. I don't think there's a question about that there's a specific tropism of stem cells towards the tumor cells. Now, what can we do with these red cells? So our target are the green cells, and our friends here are the red cells. Can you modify red cells in such a way that we can kill these green cells? Because it's great. You don't have to. One of the big problems with brain tumors is that the drugs don't go to the tumors because of the blood-brain barrier, and so systemically injected drugs do not do anything in these patients. Can we modify something? These cells here, they can kill the green cells, and that's the whole story. So we've identified over years receptors on the tumor cell and the endothelial cell, and figured out that we can now target these receptors. These are EGFR, DR4/5, IL-13 receptor alpha-2, CD36, both on endothelial cells and the tumor cells, and then a nectin-1 receptor on the tumor cell. I put this separately for a specific reason. So you can engineer stem cells, release ligands or antagonists that bind either to these receptors simultaneously to two receptors or individually to each receptor, and then can kill these cells. And then this part is we can now load oncolytic viruses here in these cells, and they can be released by the stem cells and kill the tumor cells. So this is the big biology of behind what we do. Now the question is, this is fun. I mean, say, we can do it. There are 50 other labs in the world who can do it as well, and they're doing this. The question is, how do you actually take this to clinics? And I think that's the specific thing I'm going to put a lot of emphasis in next 10, 12 minutes. This is a neural stem cell engineered to express trail. So it doesn't kill the green cells. It's a releasing trail that you don't see, but you will see the red cells being killed within the next 10, 15 seconds. So trail is one of the therapeutic molecules that binds to death receptor 4 or 5 on the red cells and starts killing. But look at these cells. These cells are alive and healthy, and these cells are dead within 48 hours. So now if you take a purified trail and put it on these cells, they will kill, but not as extensively because trail has a very short half-life. Now, if you do the math, in 48 hours, most of the cells are gone. Again, the green are the cells releasing trail, the red are the tumor cells. And as I pointed out, there are major challenges. I mean, say, we've done this, other people have done this. Okay, what then? And if you talk to a person who develops systemic drugs for tumors, they say, well, this is not going to go anywhere. And I think that's a very valid question, that this has been happening for the last 15, 20 years, and we haven't taken this anywhere. What's the reason? The reason is that we don't have real tumor models. We just try to think that we can take a patient cell and put it in the mouse brain and treat this, and this is our treatment. And then we say, well, FDA didn't approve it. Of course they wouldn't, because it's not really doing anything there. So then the second thing is, most of the cell therapy people, they don't really look at the molecular mechanisms. They don't really look at, like you do this with small molecule inhibitors or drugs. They will basically tell you why a drug works and why a drug doesn't work. So this is one of the keys, that if you have to incorporate molecular mechanisms. And then we're not, again, looking at current standard of treatment. How do you actually, what is currently happening with the patients? How can you just incorporate your therapy into this? And then, can we image in real time what is happening to make go, no-go decisions? So I'm going to give you three examples of how we've taken some things almost to the clinics. So let's go back to the brain tumors, the tumors in the brain. Let's assume somebody had a seizure and went to the OR and got an MRI, and they tell the person that you have a big lump in the brain and it needs to be removed. 99% of the times it's a tumor in the brain. So they go to the OR, the operation is scheduled within 15 to 20 days or within a month, and the neurosurgeon, the clinician here, is a part of the panel, and the patient and the clinician decides how much I can resect. So most of the time, 75% of the times, these patients get tumor resection. And this tumor here, and we've now extensive data showing this tumor behaves completely different than a solid tumor at that stage. So it depends on the neurosurgeon, how much and how aggressive they are and where the tumor is in the brain, how much they take out. So after that, what happens is that the patient gets treated with temozolomide and radiation. After 9-10 months, the tumor reoccurs either at the same place or somewhere else, and the patient dies within 18 months of the original diagnosis. So this is, again, as I said in the beginning, this has been happening for the last 2 decades, 3 decades, and I don't think we have found any answer. So we try to mimic this in the lab, and doing a resection in a mouse brain is not one of the easy things. I was lucky that we got a few neurosurgeons involved in this and tried to mimic this, tried to implant the fluorescent and the bioluminescent cells in the brain and resected as you saw in the video, resected as the neurosurgeons do in the humans. You see here, tried to vacuum it out, and this is the culprit. This is the excised tumor. These are the cells that remain there. And the question is, can we treat these cells here? And we're not the only ones. So first, the model. So model actually tells you, yes, we have resected the tumor. It was necessary. You get survival benefit in mice. The question now is this cavity that is created after resection. Can you put something there? And people have put things there. We were not the first people to thought, okay, we can put stem cells there. People have put temozolomide wafers there. Oncolytic viruses have been put there. And we've done some extensive studies where we've tried in parallel putting those things in the resection cavity, and most of them get washed away. So if you go to the OR, and are next to the patient when it's being resected, this cavity gets filled with cerebrospinal fluid and blood in no time. So you basically, anything you put there gets washed away. So we tried stem cells, and they got washed away. And then we got into, I met somebody at Biotime, which was glycosan initially, and they said, how do you grow your tumors? And we said, well, we just put it in the brain. They said, maybe you should put it with the hydrogel, hyaluronic acid-based gel. I said, well, we don't have any problems growing our tumors. Maybe we can put stem cells in our hydrogel and place this in the cavity. So we took hyaluronic acid-based gels, it's high stem C, and we mixed, so these are basically liquid, and mixed it with the cells and place it in the cavity. So the cells sort of form a gel, and this is how the cavity looks like. This is one type of tumor, this is another type of tumor, and basically these are the residual cells. Green are the stem cells releasing trail, and you see almost 100% survival benefit in mice. And of course, with the gel, they survive longer, and without the gel, they get washed out. This is good. This is what we have now tried to make a bimodal cell, because FDA wanted us to have a suicide gene in there so we can eliminate stem cells if they might cause any malignancy, if they have the potential to cause any malignancy. So we have incorporated HSV-TK, that's a suicide gene. So this is a bimodal cell that expresses trail, has HSV-TK, and can be eliminated after giving ganciclovir, and can be imaged by PET. So stem cells can be followed in real time post-therapy. So the question is, how do you actually do this in the patient? And how do you actually monitor patients? So it turns out that the therapy you saw here is great in this model. And Nature Neuroscience people asked us to write a big discussion on what could happen to patients that do not have death receptors 4 or 5, or that do not get killed with trail. So there are 40% of the tumors that do not have death receptors 4 and 5 and wouldn't get killed with trail. So what we went back, I didn't put the publication details here, but we've done this in mouse now, where we have taken the blood from the mice bearing tumors in the brain and done CTC isolation, circulating tumor cells, and looked at that we can find circulating tumor cells, the brain tumor cells in the blood, and we are now looking at death receptor expression 4 and 5 in these cells. So you can do this prior to having patients, sort of lined up for therapy, that you can look if they have death receptor 4 or 5 before you can line them for therapy. And then we've also now calculated from MRI data how much is this cavity in patients. So we've taken 15 to 20 patients pre and post MRI data, and have calculated that the cavity size is around 49 to 50 cubic centimeters. So we can calculate roughly how much cells go into this cavity, and this around 60 million cells in the resection cavity, an average of 60 million cells in the cavity. And based on that, we couldn't do this in the academics. I tried it for a couple of years, so we had to create a small biotech. which now focuses on basically taking this into clinics, has raised roughly $2 million to pay the lawyers and talk and have a company that is talking to FDA. So we had our pre-IND done. We're now sending more data to FDA for our IND, which hopefully in next 6 to 8 months should happen. So it's a very clear path. So when the patient has a brain tumor, of course it will be easier for us to get the blood, look at the circulating tumor cells, look at the DR4/5 expression, stratify patients that have the death receptor expression, and we have the cells. These are allogenic cells that are engineered with TRAIL and TK and are already banked. The question then is, could you do this with autologous cells? The answer is no. I think we had a discussion yesterday about this, because these patients have only 20 to 25 days between the detection and when you can implant in these patients. So basically, you need something off the shelf. I know off the shelf might not be the real thing, but that's the only option in these patients. So the question then is, going back to the patients, so of course the lab is not only interested in taking this into clinical trials, but also interested in developing future therapies for not only brain tumors, but also other cancer types. So we've now a cohort of 60, 70 lines from patients. We have classified them into invasive, non-invasive, and semi-invasive tumor types based on our imaging profiles that we take the patient's lines, put them in the mice brains, and create these tumors. And of course, they have different sensitivities to TRAIL. Some are TRAIL resistant, some are semi-resistant, some are not resistant at all. And the other issue, as I said, we have also now tried to see if we can take this invasive tumor that is extremely invasive, doesn't form a solid tumor, but just goes across the corpus callosum, and you can now put stem cells there and they can migrate to distant areas. So I think we've answered one of the questions. The second question we're trying to answer is that the cells that are TRAIL resistant, how do we actually make them TRAIL sensitive? And there are a number of ways to make them TRAIL sensitive. You can give etoposide, you can give temozolomide that is known to result in TRAIL sensitivity. But I think what we were interested in, can we target two different receptors at the same time? And one of them becomes the sensitizer and one of them becomes the killer. So we've recently created stem cells that now express a bispecific nanobody TRAIL. Nanobody is the functional unit of an antibody that binds to EGFR, and DR5/4 TRAIL binds to DR5/4/5. So basically, what we've done is we've taken the llama nanobody that we fused to TRAIL and shown that it binds to both receptors at the same time. And these are all extensive studies, which I'm not going into the detail, as both receptors are in a 10 nanometer distance. So TRAIL binds to both of them. TRAIL and nanobody TRAIL binds to both of them and induces apoptosis in resistant cells that are resistant to TRAIL now. So you have now a stem cell that can release a bifunctional molecule and kill tumor cells in vivo. So the last 3-4 slides, and I'm going to talk about this a little bit. It's very exciting, and I wanted to end my talk here, but I thought this was fantastic how we could use oncolytic viruses. Oncolytic viruses in last 3 or 4 years have gone, have been approved for clinical, have been approved for patients in melanomas. Oncolytic herpes has recently been approved for melanoma patients. So there's a lot of buzz about oncolytic viruses, and now because of the immune therapies as well, they invoke immune response. So it's going to be the next generation of therapies. I strongly believe that, and I don't think we've done the work prior to being in vogue, but I think it's important to see how we can use them in the context of what I explained to you initially. So oncolytic viruses only kill dividing cells and not the normal cells. They need a dividing cell. So how do we use them in this context? So as I told you, people have put oncolytic viruses here, and they get washed out. You can't do that. So we need something. Can we use the cell? Yes. Can we use the gel? Yes. So what we've done is we've taken the oncolytic virus, put it in a mesenchymal stem cell, and it kills a mesenchymal stem cell 24 to 48 hours later than actually it kills the tumor cell. So you can use that time to kill the tumor cell. So you load the stem cells, they get killed at 120 hours. Now if you, so this is a movie where you have the green tumor cells, the red cells have been loaded with the oncolytic virus that express red. So if you see this, the red transfers into the green, so the virus goes from a red cell to a green cell, everything becomes yellow, red, and then they're dead. It's my rhyme for the talk. But this is robust. This is amazing how this happens. Now, if you really, so oncolytic viruses do the job. Now, if you have to be street smart to use them. I think that is the problem we have had. We sort of relied too much on them, but haven't really had very smart, innovative ideas how to really take them into clinics. We don't need systemic drugs. We don't need anything if you do this properly. And I think, the beauty of the oncolytic viruses is that they will not survive if there's no dividing cell. And there's no dividing cell in the brain without the tumor cells, so they're going to be killed anyway. So it's like the influenza. So how do we do this in this context now? So what we did is, this is in an intact tumor. We took a mesenchymal stem cell, put it at the edge of the tumor in the brain, and you see over 78 hours, this takes over all the tumor. And, I can give you $100 now if you can find a drug that does this in 72 hours, giving it systemically in a brain tumor, in a mouse with a brain tumor. It won't happen. This is very simple. You see, at 72 hours, and we've incorporated imaging that tells you exactly what happens when. And at 96 hours, most of the cells are red and gone. And as soon as the cell turns red, all the cells are gone. So now, how can you use this in this context? And we've tried to put oncolytic viruses directly in the resection cavity, and they're gone after 7 days. But if you load them in the MSCs, and put them in a gel, and put them in the cavity, they transfer from a stem cell into a tumor cell, and then result in the survival benefit. So this is, we can optimize it further, because there's a lot of potential in the resection cavity. So this is one of the, so we've also modified oncolytic viruses to make them more potent, which I'm not going into the detail. Two last things, as I told you in the beginning, that a lot of tumors from other parts of the body go to the brain. Now, we know that, this is somehow not, something is missing here. So this is an MRI from a melanoma patient, which has tumors here, 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 and you see tumors everywhere. You can't resect this, so you have to have a different model, completely different therapy for such tumors. But first, have we developed models that mimic this? The answer is no. We haven't developed models, and I'm really surprised, since we started doing this last 3 years ago, there isn't a model that mimics this. How can we develop therapies for metastatic tumors that go to the brain if there's no mouse model? What we do is we take a metastatic cell from a patient and say, now we can implant this in the brain directly, and this is our metastatic model, but that's not right. That is not actually how it is mimicked. So if you look at this, so this is the arterial system that goes to the brain. This is the two carotid arteries, right and left. And so the tumor cells, let me explain to you how tumor cells go. They go to the brain, is how we inject them, and they form these metastatic deposits everywhere. But this is how, from the breast and from the melanomas, how they end up here. This is the way they try to go in 3-4 years from the primary breast tumor to the metastatic tumor. They try, and then after 3 years, they somehow manage to cross the blood-brain barriers. They change the gene expression on the surface and manage. So we've taken these mouse cells, and so sort of our therapy has to be something like this. So we can now inject cells here, and these cells will go and track all these cells that are there in red. So we've developed two models, BRAF, and the paper is in Nature now. This is BRAF wild type and BRAF mutant. These are from patient-derived. So these are from metastatic tumors in the brains of the patient, which we have gotten the lines from and developed models that mimic exactly the clinic. So you get single deposits, 8 or 9 deposits, and you can actually see where they are. They're all over the brain. They're not at a single place. And then what we did, we injected the stem cells loaded with the virus in the intracarotid artery. And if you inject the virus alone, it doesn't go anywhere. You don't see anything. The virus is red, and the stem cells become red because of the virus. And you see that at 120 hours post-ICA injection, most of the cells start becoming yellow and then red. So this is basically where we are. We've done therapies. Again, I don't want to go into the details, but there are 2 different models, 2 different ways, similar concept. But again, if you now summarize this, what I've just told you, that the cores are critical. The tumor cell bank, vector design, so it takes a lot of lentiviral vector design with which we modify our stem cells, and then the stem cell banks where we get the stem cells from, which stem cells, disease-specific stem cells, and then clinically relevant mouse models. Again, if we don't have the mouse models, we really cannot say we have the therapy. And I think that's the problem, particularly with cancer. If we don't have a right mouse model, it won't work. And then cell therapy for cancer and neurological diseases. And from here, what we've done is we've so for people in academics, they're very good till here. This is their comfort zone. They love this because this is where they write grants, they get grants, and they get papers, and till here, they're excellent. This is where the tough road is. So to jump from here to here is a tough road. And when we started, I went to Leslie Silberstein. Brock knows him well in Harvard, and he told me, I have people like you who come to my office, and 99% of the people don't show up again. And I was really surprised, and he said, well, no offense to you, but the reason is because it's a very uncomfortable zone for you guys to come back here and start dealing with this. So I took it personally, and I told him that I'm going to come back one day. And I think he acknowledges this, that I am coming back very often. I think this is the road. This is where, it's not just making companies, but I think you got to be, sort of really involved here. And you can let it go after this. It's very uncomfortable for me to be a part of the company and also run the center and my lab, but I think I want to take it to a level where nobody sits on it, that it goes to the next level, because I know both sides now. And I think we need to create more people like this, and for Sense Foundation and for Buck Institute, I think you need to have more people in this space who can work here so that you can innovate and take this into patients. And I think that's what we're lacking, and that's what needs to be done if we have to make a difference in patients' lives. So I really want to acknowledge, Ji-Hoon is here. He has taken some of our virus work into melanomas now. This is now, my lab, and now, transforming into a center. And without these people, I can't be standing here. They do some fantastic work. And I really want to thank these people and the collaborators that we have. And I want to leave with this. Albert Einstein once said, and I don't know whether he was dreaming or he was doing an experiment which revealed E is equal to mc squared. But I think that's you have to, I was reading a book called Mind Magic, and it tells you that there is a certain zone beyond subconscious zone which you need to be thinking in and believing in. And if you don't think in that zone, things don't happen. And this is like Elon Musk. If you don't think like I'm going to live on Mars, it's not going to happen. So something we have to believe, but I think we have to be realistic as well. And I think patients are key players if we don't understand what they need, and then clinicians who work with patients, and I will add to that academicians who are the key to innovate, and I think the marriage between the three is going to help us succeed in future. Thank you.